Skin cancer is the most common cancer in the body, but it is a controllable type of cancer. That's to say, if we are early diagnose these conditions, we can control these cancers. The etiological factors, we have radiation, we have hereditary condition, we have chemicals like scrotal cancer and chimney sweeps, and then we have the pre-malignant conditions. These still are benign, but can transform to malignant conditions. And you can see that one of them is actinic keratosis. Actinic keratosis are pigmented lesions on skin exposed areas, especially on the face and the hands, on old age patients, and it has 15 to 20% risk of developing squamous skin cancer. Bound disease is another condition that is formed like these lesions again on sun exposed areas, and with the biopsy it shows that it has some of anaplastic changes, but still it is a benign condition. Erythrodysplasia of Kuric is warty-like lesions on the skin in the prepuce area. It could be of viral origin. Again, it has its percentage of developing squamous cell carcinoma. Leukoplakia is another condition, and the leukoplakia, as you know, that it occurred on the mucous membrane, and you can see that there is some of the white color lesions surrounded by a red base in heavy smoker patient on sharp teeth here or there, and they can develop squamous cell carcinoma. Another condition like keratoacanthoma also, although it is called self-limiting squamous cell carcinoma. So it has a lifespan, and with time it has a regression period. Radiation dermatitis is another pre-malignant condition. In those patients with radiotherapy, you can see that the areas start to have more redness, and with time another cancer may develop. So patients come for treatment of cancer and then end with another cancer. No. لا لا ست دقائق. Xeroderma pigmentosum is another condition, and the patient have autosomal recessive condition, and those patients will have many manifestations. We will talk about this manifestation later on. We have mainly three main conditions for skin cancer. We have basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. The basal cell carcinoma is the most common type, and again, it is commonly occurred on the face, head and neck region. It is slowly growing, but with massive silent penetration. So, because it is symptomless, patients are usually presented late. The cell of origin is the basal layer of the epithelium. But these anaplastic cells are leaving its original site to invade the underlying tissue, to the deep dermal tissue. You can see there are collections of cells leaving the layer, which should be here, but it starts to invade with these nest of cells. Clinical types, main type is the nodular ulcerative type, and it is usually single lesion, and it can be found on the head and neck region. In contrast to the other part, which is the superficial type, which is usually of multiple lesions found elsewhere. You can find it on the trunk, on the limbs, and so on. The most dangerous one is the third one, which is the sclerosing morphea type. And this type is associated with more vertical metastasis. Once the tumor is of radial metastasis, it's usually controllable because it's still with the skin. So we can excise it and replace the area by whatever the mean of the replacement, whether skin graft, flap, or whatever. But once it has a vertical extent, there will be more metastasis. The pigmented one is the fibroma-like. Pigmented because it is with hyperpigmentation. And this should be differentially diagnosed from malignant melanoma, yes. The rodent ulcer is referring to the ulcer that is occurred between two fusion lines. Supposing that we have the nose and the cheek, so here the layers of the skins are usually little layers, are thin. So it can easily invade to the deeper tissue. And once it's reached to the bone, it's usually of difficult procedure. Superficial, this is the nodular ulcerative type. This is another nodular ulcerative type, but here we can name it as a rodent ulcer because it's between the nose and the eyelids. Another nodular ulcerative type. This is another example of basal cell carcinoma that it invades all the layers of the ear from anterior to the posterior, and you can see that on the post-auricular space we have telangiectasia. Once you see telangiectasia or prominent vessels, that means there is high malignant process. So this is a bad sign. And after excision, we can sacrifice all these layers, even part of the facial nerve was involved. We have syndromes associated with multiple basal cell carcinoma, and the most common one is the xeroderma pigmentosa. It has many manifestations, like eye manifestation, like photosensitivity, photophobia, CNS manifestation ranged from headache, epileptic fit, and even mental retardation. And the skin is presented with multiple skin tumor, whether in terms of basal cell carcinoma, squamous cell carcinoma, or even malignant melanoma. The second one is the Jordan syndrome. Jordan syndrome is an autosomal dominant condition associated with palmar pits, and you can see that the patient will have also bone cyst. Examining the palm, sees these pits on the palm. Another condition is the basic syndrome, and the basic syndrome there is atrophoderma and anhydrosis on the palm again. It's also autosomal dominant condition. The main treatment for basal cell carcinoma is surgery, providing that it's more than 4 millimeters in diameter. Less than 4 millimeters in diameter, we can use the conservative way, whether in terms of curettage desiccation, cryotherapy, radiation, dermabrasion, chemical peel, interferon alpha, 5-fluorouracil, which is local cytotoxic drug, and ablative laser. But once it's more than 4 millimeters, we go forward for the surgery, and the surgery should be with a safe margin. And what we mean by safe margin is the normal skin to be excised away from the tumor to ensure low recurrence rate. This patient is having nodular ulcerative basal cell carcinoma, and with the excision, most of the lower eyelid was excised and replaced by a flap. Another patient, we excised the tumor and replacing that area with a flap from one lip to lose the defect on the other leg. For any patient operated after basal cell carcinoma, we need a follow-up program. And this follow-up program should be every 1 month for the first 3 months, then every 6 months for the subsequent 6 months, and then every 6 months for the 2 years then after. So by this way we can detect any possibility of recurrence. And here we are searching for presence of scarring, presence of crustacean redness, presence of any telangiectasia, development of papule nodule formation, and any tissue destruction. So it is not a matter of just operating the patient and go home. We need a follow-up program. A patient with previously excised tumor on the eyelid is presented with this picture. And here there is deeply invaded metastasized tumor inside the globe and contracted eyelid. And after total excision, we sacrifice all the globes of the orbit, and then it is a disaster how to live with such a figure. Another patient with recurrent basal cell carcinoma on the skin graft area, while a patient like this with positive intracranial metastasis was inoperable. This is all about the basal cell carcinoma. Now we are going to the squamous cell carcinoma. Squamous cell carcinoma is originated from atypical keratinocytes, and again we have predisposing factor. The same predisposing factor for all of the skin cancer, but here we can add something like arsenic intoxication, immune suppression, and human papillomavirus infection. Keratinized areas deeply invaded to the dermal tissue seen by histopathology. And we have clinical types, slowly growing or mesophytic. Once the tumor is growing outside the body, this is called exophytic, and this is usually of better prognosis. Once the tumor is going inside or endophytic, it is usually rapidly growing, which is of poor prognosis. Now, this is a picture of squamous cell carcinoma. What is the difference between this picture from the previous pictures you see? Yes. شو الفرق بين هاي الصورة والصورة اللي شفناها مع البيزل؟ More is margins are vertical, yes. Larger size, yes. telangiectasia ممكن اكو part منها بالراس lower بالراس size, yes. More ugly and large size vertical margin. شوف هاي المنطقة، هذه من more blood supply، يعني التيومر ده بياخد أكسجين and nutrient consumption more، يحتاج more blood. شنو؟ إيه هو طبعا هو موجود هناك موجود هناك بعد there is tissue destruction. There is tissue destruction with necrosis. You can see that the central part is black color. So there is more tissue destruction, more necrosis. The margins are more irregular and the edges are more erect. You know what's the difference between the margin and the edges? What's the difference?
Edge of the ulcer.
What's the difference between the edge of the ulcer and the margin of the ulcer?
Margin for lesion. And edge for ulcer.
لا لا هو اثنيناتهم للأسف. نعم. هذه ما لها اللي هو margin is what you are seeing from above. So you can see that this is a circular, regular or irregular. The edges is the cross section. What you see by cross section. So you can see inverted, undermined, punch out, sloping. All these are the types of the edges. Okay. A patient with exophytic lower lip squamous cell carcinoma, and you can see here the excision safe margin should be at least how much? For the basal cell carcinoma, it was 5 millimeters. For the squamous cell carcinoma, how much? At least 1 centimeter, all around and even deep to the lesion. A patient with such an ugly lesion invaded all the layers with drawing of the saliva with bad foul smell was another example of neglected squamous cell carcinoma. Differentially diagnosed from actinic keratosis, from keratoacanthoma, seborrheic keratosis, wart, and basal cell carcinoma. Actinic keratosis is sometimes called as self-limiting squamous cell carcinoma. Why it's self-limiting? Because it has 3 main phases. It has an involuted phase, or progressive phase, static phase, and involuted phase, or regression phase. And this is, for each phase, it's around 8 weeks duration. If we see the patient during the first 8 weeks, we can say this is a squamous cell carcinoma, and we go forward to select all of the nodes. While if we just wait and a good histopathologist give us a diagnosis of keratoacanthoma, we can just wait and after regression dealing with the defect with just a composite graft. That's to say replacement of the angle of the node by just a piece of ear called composite graft.
Is it more severe than
No, self-limiting. Again, we have syndromes with squamous cell carcinoma. One is xeroderma pigmentosa, erythrodysplasia grossi-formis. ده التشجر، وهذا ده التشجر مرة صار عليه ضجة انه طبعا هنا يصير اكو عندنا bulbity warty like lesions with it could be autosomal dominant condition, although the main cause was unknown, but it may be of viral origin. While Moore-Torre syndrome is another condition, and here we need to search for presence of internal malignancies. It could be in the large intestine associated with keratoacanthoma, again of autosomal dominant condition. There is a technique called Mohs micrographic technique, and this is we can preserve the normal tissue and precisely excise the tumor itself and preserving the normal tissue. So the matter of 5 millimeter in the basal cell carcinoma or 1 centimeter in squamous cell carcinoma will not working anymore by this technique. You can excise little amount of normal tissue by this technique. The same as for frozen section. You know what's the frozen section? What do we mean by a frozen section? Frozen section is the way how we can diagnose a specimen of tissue intraoperatively. That's to say, during the operation, if the surgeon is suspicious whether this part of the tissue is involved or not involved by the tumor, so we can send the specimen to a side lab, that's to say, beside the theater, and diagnose whether it's positive or negative. The same can be said for the skin cancer by this way. But the difference here is the specimen will be in transverse rather than vertical way, and the stain will be in terms of zinc chloride. Now the last part of our skin cancer lecture today is the malignant melanoma. Malignant melanoma are the second killer cancer in man. Which is the first? Prostate. And it arises from neural breast derived cells. What you see in this picture? Irregular pigmented skin region and with variant color, you can see. Not all of the color is the same. Yes. So there is variant color from deep part to more light part. And it is asymmetrical, not symmetrical. You can see these cells are again invaded to the deeper layer, and this is the significance of the malignant melanoma. The types, superficial spreading type, which composed 50 to 70% of all malignant melanoma, nodular melanoma, which composed only 10 to 20%. The amyloidic melanoma is associated with hypopigmentation, and this is again a strange behavior of the tumor. We have lentigo malignant or Hutchinson freckles. We have acral melanoma, which is very dangerous, and this plastic melanoma. Once the melanoma starts to ulcerate spontaneously, this is a bad sign. That means the tissue necrosis is enough to cause ulceration. In this patient, malignant melanoma on the shoulder, seen as to be ulcerated, but that one, she was not ill because the ulceration was not spontaneous, it was by friction of bra, so it was excised with a safe margin. Safe margin here should be at least 5 centimeters. Indication of taking a biopsy from any pigmented lesion. You know that most of our bodies having pigmented lesions here or there, but when we need to take a biopsy according to presence of at least one of these parameters, it summarized as A, B, C, and D. A means asymmetry. You can see the difference between the benign and the malignant are regarding one, symmetry. You can see asymmetry or symmetry. B is the border, okay, and these the borders. You can see that it is regular, or here particular, the color, once the pigmented lesions start to have deep color over a short period, this is a bad sign. So you should take a biopsy from that lesion to be away from the possibility of malignant melanoma. The diameter, again, some of them say 6 millimeter or 8 millimeter. So 6 to 8 millimeter in diameter. Below that, regarding as benign, more than that, regarding as malignant. And E is evolving E protrusion in outside direction. We have prognostic factors, and these prognostic factors can be in Clark level. The Clark level is the tumor in the epidermal, level 1. Tumor is starting to invade the papillary dermis. This is Clark 2. Clark 3 is junctional. Clark 4 dermal, and Clark 5 to the underlying tissue. The more accurate one is in terms of Bristow, which is the thickness. This is more accurate prognostic factor. 1 millimeter thickness of the tumor is Bristow 1, 2 millimeter is Bristow 2, 3 Bristow 3, and Bristow 4 is 4 millimeter and more. This is regarding the thickness. Ulceration, as we said, is a bad prognostic sign. Type of primary lesion, again, is another prognostic sign. We have the septal listosis. And septal listosis, that means the primary tumor is in the center, surrounded by local metastasized nodules. So these are septal listosis. Grave sites are summarized as A. A is the acra, G is the genital, and A is the ear. Yes. Acra, genital, and ear. The poor is summarized by bands. Band is back, arm, neck, and scalp. Part, arm, neck, and scalp. All malignant melanoma should be differentially diagnosed from conditions like dysplastic nevi, pigmented basal cell carcinoma, seborrheic keratosis, blue nevi, dermatofibroma, pyogenic granuloma, and Kaposi sarcoma, which is soft tissue tumor. We have pre-malignant pigmented lesions, mainly 3 conditions. One is more than 100 nevi, that's to say large number of nevi, or one giant nevus more than 10 cubic centimeter in diameter. This is called congenital giant, maybe hairy nevus as well. And this is plastic nevus. This is a condition of giant hairy nevus involving the scalp. And the difference from the normal scalp is the skin color. Normal scalp is usually normal skin color, but this is a black color. So this is a giant nevus. Another giant nevus here on part of the face. Giant hairy nevus on the lower leg and the foot. We have stages of malignant melanoma. Stage 1, when it is localized to the skin. Stage 2, when there is spread to the regional lymph node. Malignant melanoma is different from both basal cell carcinoma and squamous cell carcinoma by the mode of metastasis. It prefers the lymphatic metastasis rather than blood metastasis. So once it reaches to the nearby blood lymph node, it's stage 2. Stage 2 plus metastasis to other part of the skin or other organs is stage 3. Treatment is mainly surgery with at least 5 centimeter safe margin. But for a 5 centimeter on a finger, even on the hand, may be a disaster. So malignant melanoma could end with amputation. Some of the conditions need even electively excising the lymph node, as if we are dealing with CFS. So here, even the lymph node is negative for the tumor, we can electively excise the regional lymph node, providing that the patient can withstand such long operation, or is in a young age, but for the old age people, it is not indicated. Regional perfusion. For a tumor involving a limb, we can do closed circulation and controlling the tumor on that part. So we can simply apply a tourniquet and giving IV injection of one of the cytotoxic drug called malferan, and keeping the tourniquet for about 1 hour and then releasing that part. So this is called closed perfusion or local perfusion or regional perfusion of cytotoxic drug. Chemotherapy is another mode of treatment, and interferon alpha 2b is a type of passive immune therapy treatment. What about radiotherapy?
Resistance?
It is radio resistant. So no role for any